Squamous cell carcinoma of the skin, recognition, diagnosis, and management. Cutaneous squamous cell carcinoma represents a common and potentially serious form of skin malignancy. Early recognition and appropriate treatment significantly improve patient outcomes and reduce complication risks. Understanding squamous cell carcinoma of the skin. Squamous cell carcinoma of the skin, medically referred to as cutaneous squamous cell carcinoma, CSCC, stands as one of the three most prevalent categories of skin malignancy affecting millions of individuals worldwide. This condition arises from the uncontrolled multiplication of squamous cells, which comprise the upper layer of the epidermis and represent the most abundant cellular component of the skin's outermost structure. The disease occupies an important position within dermatological oncology due to its relatively high incidence rates, variable clinical presentation, and potential for both local tissue destruction and systemic spread if left untreated or inadequately managed. Understanding the fundamental characteristics of this condition proves essential for both healthcare providers and patients in achieving optimal diagnostic accuracy and therapeutic success. Clinical presentation and identifying features. The appearance of cutaneous squamous cell carcinoma varies considerably among affected individuals, reflecting differences in tumor biology, anatomical location, and host factors. The most characteristic presentation involves a firm, indurated nodule featuring a rough, keratotic surface that may demonstrate irregular borders and variable coloration. The lesion frequently exhibits scaling or crusting, and the surrounding tissue may display signs of inflammation or erythema. Alternatively, some tumors manifest as erosive or ulcerative lesions with rolled edges and a granular base, occasionally with a hemorrhagic or necrotic appearance. The development process typically unfolds gradually over several months, allowing patients and clinicians an opportunity for early intervention if vigilance is maintained. Location matters significantly, with predilection for sun-exposed areas including the face, ears, neck, forearms, and dorsal hands, though lesions can develop anywhere on the integument. Risk factors and etiopathogenesis. Key points: chronic ultraviolet radiation exposure, particularly UVB wavelengths, representing the primary environmental risk factor for malignant transformation. Fair skin complexion and diminished melanin production, resulting in reduced protection against solar injury. Advanced age, reflecting cumulative lifetime exposure to carcinogenic insults and declining cellular repair mechanisms. Immunosuppression from medications, organ transplantation, or systemic disease states that compromise anti-tumor immune surveillance. Pathological classification and staging. Histopathological examination under microscopy reveals neoplastic squamous cells demonstrating varying degrees of differentiation, nuclear abnormalities, and mitotic activity. Well-differentiated tumors retain some recognizable squamous features and generally follow a more indolent course, while poorly differentiated variants show extensive cellular atypia and correlate with more aggressive biological behavior. The depth of invasion represents a critical prognostic indicator, influencing both recurrence likelihood and metastatic potential. Anatomical site-specific staging systems incorporate tumor dimensions, histological grade, and host factors to stratify patients into risk categories. Low-risk lesions typically measure less than 4 mm in depth, demonstrate well-differentiated histology, and lack high-risk features such as perineural invasion or immunosuppression. Conversely, high-risk tumors exceed these parameters and warrant intensified surveillance and potentially more aggressive therapeutic approaches to minimize adverse outcomes. Diagnostic evaluation and confirmation. Clinical suspicion based on morphological characteristics and patient history forms the foundation of diagnostic workup, though definitive diagnosis requires histopathological confirmation through tissue biopsy. Various biopsy techniques exist, including punch biopsy, shave biopsy, and excisional approaches, each offering specific advantages depending on lesion size, location, and clinical context. Dermoscopy, a non-invasive magnification technique, facilitates improved visualization of microstructural features and may enhance diagnostic confidence in experienced practitioners. Imaging studies such as ultrasound or magnetic resonance imaging occasionally assist in determining depth of invasion and assessing regional lymph node involvement in advanced cases. Staging investigations become appropriate for high-risk lesions or those with clinical features suggestive of metastatic disease, though most cutaneous squamous cell carcinomas remain localized at the time of diagnosis. Complete blood work and laboratory analysis generally lack utility in routine assessment unless specific clinical indicators suggest systemic involvement or internal malignancy. Treatment modalities and therapeutic options. Treatment selection depends upon lesion characteristics, patient age and health status, cosmetic considerations, and anatomical location. Surgical excision with histologically confirmed clear margins remains the gold standard therapeutic approach for the majority of cutaneous squamous cell carcinomas. This technique provides excellent local control rates and permits complete histological assessment of the specimen, ensuring that malignant tissue has been adequately removed. Mohs micrographic surgery offers particular advantages in selected cases, particularly tumors in cosmetically sensitive locations or those with aggressive histological features, as it enables complete margin assessment during the surgical procedure itself and maximizes tissue conservation. Key points: surgical excision with standard margins suitable for low-risk lesions in non-critical anatomical sites. Mohs micrographic surgery for recurrent tumors, perineural invasion, or lesions in functionally important areas. Electrodesiccation and curettage for small, well-differentiated tumors in low-risk locations with excellent cosmetic outcomes. Cryotherapy employing liquid nitrogen for superficial lesions, though with limited tissue sampling capabilities. Metastatic potential and prognostic considerations. While the majority of cutaneous squamous cell carcinomas remain localized and present an excellent prognosis with appropriate treatment, regional lymph node metastases occur in approximately 4 to 5% of cases, and distant dissemination affects fewer than 1% of patients. However, specific high-risk features substantially elevate metastatic risk. Tumors demonstrating poor histological differentiation, depth exceeding 4 mm, evidence of perineural or lymphovascular invasion, or diameter greater than 20 mm warrant heightened concern and more intensive surveillance. The anatomical site influences biological behavior, with lesions on the ear, a lip, or scalp demonstrating more aggressive tendencies compared to trunk lesions. Immunocompromised individuals, including transplant recipients and those with hematologic malignancies, experience substantially elevated recurrence and metastatic rates despite therapeutic intervention. These patients require more aggressive initial treatment and prolonged surveillance protocols to identify recurrent disease expeditiously. Surveillance and follow-up management. Following successful treatment of the primary lesion, ongoing surveillance assumes paramount importance in detecting recurrence or development of new malignancies. Patients with low-risk disease benefit from periodic clinical examination at intervals ranging from 3 to 12 months, with emphasis on both the treatment site and the entire integument, given the heightened field effect and propensity for multiple independent lesions. Those with high-risk tumors require more frequent assessments and potentially regional lymph node examination or imaging. Patient self-examination techniques and education regarding warning signs facilitate early detection of recurrent lesions. The development of multiple squamous cell carcinomas in the same individual necessitates discussion regarding systemic risk reduction strategies including broad-spectrum photoprotection, retinoid therapy, and non-steroidal anti-inflammatory agents, which demonstrate promise in reducing field cancerization progression in susceptible populations. Prevention strategies and risk reduction. Primary prevention through photoprotection represents the most effective strategy for reducing squamous cell carcinoma incidence. Comprehensive sun protection practices including consistent application of broad-spectrum sunscreen with sun protection factor of at least 30, protective clothing, wide-brimmed hats, and behavioral modifications to minimize peak ultraviolet exposure hours substantially diminish risk. These measures prove particularly important in childhood and young adulthood when the cumulative effects of sun exposure begin accumulating. For individuals with extensive actinic keratosis or prior history of cutaneous malignancy, systemic retinoid therapy or topical field-directed treatments merit consideration in consultation with dermatological specialists. Regular professional skin examinations facilitate early detection and expedited treatment before lesions progress to advanced stages. Patient education regarding self-examination techniques, recognition of suspicious lesions, and prompt reporting to healthcare providers constitutes an essential preventive component. Special patient populations and considerations. Immunocompromised populations require specialized management approaches due to their substantially elevated risk for both multiple primary lesions and aggressive biological behavior. Organ transplant recipients may develop hundreds of squamous cell carcinomas during their lifetime, necessitating systemic immunosuppression reduction when possible and meticulous long-term dermatological surveillance. Patients with chronic lymphocytic leukemia or those receiving immunosuppressive therapy for autoimmune conditions similarly require heightened vigilance. Elderly individuals often present with multiple comorbidities that influence treatment selection and tolerance, potentially favoring less invasive modalities despite higher recurrence rates. Pregnant patients require careful consideration of treatment timing and modality selection to minimize fetal exposure while ensuring adequate tumor control. Genetic syndromes predisposing to cutaneous malignancy, such as xeroderma pigmentosum, necessitate exceptionally intensive surveillance and preventive measures from early childhood. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.